Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound.
Quorum here, so we want to get through as much as we can before we lose anybody else. Just to welcome everyone to the meeting. I know we have some that will potentially arrive late, and we have others joining online as well. Today the committee will receive a briefing from the BDA Northern Ireland and its Northern Ireland Dental Practice Committee, the representative body for general dental practitioners, and we'll also consider a departmental written briefing on addiction services. So just the meeting is now open to the public, and the committee meeting will be recorded and broadcast through Parliament buildings and online. The clerk has received apologies from Linda Dillon and Nuala McAllister. At this stage of no others, and I know that we have Diane Dodds and Alan Robinson online, and I think Colin McGrath it will be joining online as well. So I don't think we have any other apologies at this stage. I know Orlia is on her way, but has been caught in a road traffic accident that has caused delays. Under Chairperson's business, I just wanted to reference the meeting that the Deputy Chair and I had this afternoon with NIPSA representatives in relation to the crisis in social work, particularly children's social work. And just to give people an update on that meeting. And we do want to bring some actions, but as we don't have quorum to make decisions, we'll potentially come back to it later in the meeting when we have more members. But the meeting itself was very stark, to say the least. We heard from representatives from across the 5 trust areas of just how critical it is that action is taken by the department and by the Minister in relation to social work services and children's services. We've heard of teams that are operating with no staff or below 50% of staff, the huge impact that's having on staff themselves, but also on children who are in very, very difficult circumstances, with many children going into care. We heard from Professor Ray Jones last week, who outlined the severity of this issue and the need to implement the review that he carried out urgently before this gets increasingly worse. So I think we have quorum now, with 5 of us here now. Members, what I would ask, because I'm very conscious that this issue is very, very urgent. We don't want to be in a situation where children or staff are coming to harm because of the lack of workforce and the huge issues that they're actually screaming at us now with. This isn't something that has just come out of the blue. This has been building for some time, and I know they have been in negotiations and engagement with the department, but unfortunately to date nothing has changed. So can I ask members for agreement that we write to the Minister and the Chief Social Worker for a detailed update on what has happened, what will happen, because I really do fear that this is going to really escalate. It's already in a very, very precarious situation. I can't overemphasize just how bad it is. But we need to see action urgently, and I would appeal to the Minister and the Department to take this very, very seriously. So I would propose that we write to the Minister and the Chief Social Worker to get an update on where things are at and what the plan is to tackle this issue head on. We can't wait for the implementation of the review. This is far too urgent. So do members, anyone else want to come in on that? Danny, do you want to come in as Vice Chair?
I fully agree. It was harrowing to hear just what is going on within children's social worker teams. So you're very, very concerning, and I absolutely think we need urgent action. There was an issue raised just about the legal duty. And can we have an update from the department as to where that is, if that could be part of the...
Yeah,
the
no,
as well?
I'm glad you mentioned that. I think that's important because we do need a clear understanding of where the legal duty lies in terms of the provision of services and protecting children and young people as well. Diane, you're looking in?
Yeah, no, just to say, should we consider a committee motion for the Assembly on the issue? It is something I think that health view as a bit of a tail end Charlie, you know, sort of, and I think an agreed committee motion would be quite a good thing on it. So.
No, absolutely. I think that would be helpful. I suppose the issue we have now is we've only 2 committee meetings left, and then we're into recess, so that might be take a wee bit longer. Yeah. But I think we can be working on that as well. But I would hope to see some sort of update or progress in a much more short term. Because this is really getting out of control now. So I think, yes, we can certainly look at that as well, Diane, as well as taking, you know, finding out what's happening and trying to do what we can to put pressure on to get this issue resolved.
It mightn't be any harm to put it in.
Oh no, absolutely.
We might not have it heard, but if we had a committee motion agreed by the committee, yeah, it mightn't do any harm to put it in anyway. I'm
happy with that proposal. Thank you, Diane. I think our others happy enough as well. Okay, members, thank you. So I move on into the draft minutes, which are page 6 of your meeting pack from the meeting on the 6th of June. Are members content with the minutes as drafted?
Oh, jeez.
Yeah. I have no matters arising if anyone else has at this stage. No. Okay, then members, we'll move straight into our first briefing, which is the British Dental Association, and they're here to talk about general dental services. If I can refer you to your papers at tab 5 of your pack, pages 14 and 41. Good afternoon. You're very welcome. Members in attendance today, we have Tristan Kelso, the Northern Ireland Director, Ciara Gallagher, Chair of the Northern Ireland Dental Practice Committee, and Helen Brogan, the Joint Vice Chair. So you're very welcome, and we really appreciate your time this afternoon. Thank you. We have about an hour for this session with a few members potentially joining late. There's been a few delays today, but if we can open up to yourselves then to make your opening remarks. Thank you.
Thanks very much, and thank you for inviting BDA to brief the committee on the key issues impacting on health service dentistry within general dental services. May I introduce my colleagues, Ciara Gallagher, Chair of BDA Northern Ireland Dental Practice Committee and owner of a 7-surgery mixed NHS and private practice in Downpatrick, and Helen Brogan, Vice Chair of NIDPC and an Associate Dentist working in practice in Ballycastle, providing mainly health service dentistry, and myself, Tristan Kelso, BDA Northern Ireland Director. I trust members will have found our written briefing helpful, and I'd just like to hand over to Ciara just to give her opening remarks. Thank you.
Good afternoon, Chair, and good afternoon, Committee. The critical state of health service dentistry has been highlighted in the press, and your constituents will no doubt have approached you about their own difficulties in getting an appointment with a dentist. I'd like to shed some light on the issues within health service dentistry which has left patients struggling to get care and dentists unable to deliver the care. Approximately 90% of health service dentistry is provided by general dental practitioners such as Helen and I, working in dental practices which are standalone businesses. We are not employees who are paid a salary. We are self-employed practitioners and small business owners who provide health service dentistry on behalf of the government. The government does not shoulder our fixed or our variable costs, and they do not take or guarantee our loans. We alone carry the risks of business, but we have no ability to set the fees that we receive for the treatments we provide. These fees are set by the Department of Health, who neither know nor have taken any meaningful steps to find out the true cost to provide dental care. They've rejected BDA figures. They've refused repeated BDA calls to commission an open and objective cost of service review, and they have failed to put in place a mechanism recommended by the Doctors and Dentists Review Body to determine costs. Instead, departmental affordability trumps all other considerations, and so the downward trajectory at practice level gets cumulatively worse. And it's the mismatch between rising costs and virtually static fees that is at the root of the current crisis unfolding in NHS dentistry. Morale among health service committed dentists has plummeted to an all-time low, whilst recruitment to NHS committed practices is almost impossible. After well over a decade of decline, the considerable impact of COVID-19 and a period of high inflation, health service dentistry in Northern Ireland is no longer financially viable. Our 30-year-old dental contract is grossly underfunded, it's outdated in its approach, and it's not fit for the effective delivery of modern patient-centred dentistry. So on behalf of my 720 colleagues who signed our open letter in January, I would like to ask, what is the plan for NHS dentistry? In March, the Department announced a £9.2 million investment in dentistry for 24-25, which many may have thought was a plan. I think to describe this money as an investment is misleading because it's not new money. This money has been allocated on the prediction of further shrinkage of NHS dentistry. In other words, the department know that they are driving dentists away, and so they are recycling the dentistry budget underspend and marketing this as investment. Some of the schemes in March's announcement are only due to run for the current financial year, and we're already approaching the second quarter of this year, and apart from the DDRB uplift, not a single penny of these schemes has reached practices. Now, we're deeply cognizant of the difficult budgetary situation facing the department. However, the department seems to be in no way cognizant of the impossible budgetary pressures being imposed on practices, where fees are now so financially unviable that the profession are increasingly concluding that they can no longer afford to provide NHS dentistry. So when we ask what is the plan for health service dentistry, the answer cannot be a short-term sticking plaster approach that we saw in the recent announcements. It concerns us deeply that the department chose to issue a press release announcing its dental access scheme just as the meeting between the BDA and the Minister concluded. The BDA had no foresight and they had no input into any of the proposals. And such an approach is not co-production. It breaks trust, and it's a clear illustration of the one-sided relationship that exists between the department and dentists. Now, members will know that we've worked tirelessly over the years to avoid collapse of this vital public service, to push for contract reform and a new vision for oral health for our population. But our lived experience has been one of denial, prevarication, lip service, and more recently broken promises. Between looking to Scotland for next steps and doing nothing but look, and not delivering investment proposals for last year's underspend, the profession has lost faith in the department's desire to safeguard a future for health service dentistry. Indeed, they have shown us where their priorities lie by letting £10.5 million leave NHS dentistry last year. They will say that the dental budget is not fixed and it's not ring-fenced, but a smaller spend at a time when demand is at an all-time high represents a service that is shrinking and the public are losing out on care. The fees are wrong, the contract's wrong, and the failure to listen to the needs of practitioners delivering the service is wrong, and the result is that dentists are leaving. Last year, 22% less NHS dentistry was done, with the primary reason being costs are surpassing fees. And you can see the sentiment within the profession in the written brief that we have shared with you, especially the very worrying results of our March survey, where almost 90% of dentists stated they intended to do less NHS dentistry in the coming year, and almost half stated they intended to go fully private. Now, bear in mind, these people filling in the survey are the ones who are currently delivering the service, and there is already an access crisis in this service. The exodus is well underway, and the signs are there. The submission of forms to claim NHS allowances has decreased by 30% as practices unshackle themselves from NHS dentistry. Requests to deregister patients from receiving health service care has resulted in the BSO being inundated with requests for their newly developed spreadsheet for mass deregistration, with somewhere between 15 and 25 practices currently waiting to receive their deregistration spreadsheet. So there is effectively a waiting list to leave NHS dentistry. Now, I have said a lot about the finances, but there's so much more to running a dental practice in a community than money. Dentists feel a moral and ethical tie to their local population, and it's this tie that has kept practices in the system way beyond the time that it made financial sense. It's very traumatic for dentists and for their patients when they are being forced out. They do not leave lightly. They are not being greedy. Many simply have no option. They have to be realistic about what is needed to save their practices as they see their businesses going under when they are providing much needed NHS care. Experience has shown that once practitioners move away from NHS dentistry, they do not go back. A question on a dentist social media group page recently asked, what would attract dentists who have left to come back to NHS dentistry? And the answer was a resounding nothing. Nothing would make me come back. We should be very worried about the future of our service. Last year there was a similar crisis in NHS dentistry in Scotland, and the Scottish Government stepped in to save the service. They engaged with the profession, they did their research, they accepted the utter inadequacy of the fees, and they acted. They created a new streamlined, more realistically funded payment system which has been fully costed, it's fully deliverable, and it could be implemented at pace. And if applied here, it might just about retain some of those practices who are at present making plans to leave. In real terms, the dental budget has shrunk, which is good if you work in the finance department, but it's a nightmare if you are a patient with a toothache, if you're a parent who has been up all night with your child in pain, if your elderly relative can't get dentures, and crucially, if you have a persistent ulcer, which may be cancer, and you cannot get it checked. The BDA have tried to engage constructively and proactively with the department to put health service dentistry on a sustainable footing. We have sought to create conditions that give hope to our NHS committed dentists. We've pressed for a reformed funding and a contract fit for modern dentistry. But it's apparent that there is no plan for health service dentistry, and it's with immense sadness and a touch of anger amongst my NHS committed colleagues and their patients that we have reached this point, and this situation has not emerged overnight. Like many areas across health, NHS dentistry is in crisis. However, unlike many areas, dentists don't strike, they leave, and when they leave, they don't come back. Now, this may be one of our last chances to make an appeal for action to safeguard a future for health service dentistry. All the indicators, the dental activity statistics, the future intention surveys, the volume of requests to deregister patients, and the overwhelming crisis of confidence in health service dentistry among the profession point to the reality that we have come to the end of the road. But there is a roadmap. Scotland has led the way in stabilising their dental services, and I appeal to the committee to press the Department of Health to rescue this service using the Scottish model. Further delay will drive more and more practices into private care, and we can't get them back. We believe the time has come for maximum candour on the true state of health service dentistry here and the root cause for it. I'd like to conclude with the words of some of my colleagues. From one, the Department of Health have let patients and loyal health service dentists down through decades of underfunding and inactivity, resulting in the collapse of NHS dentistry in Northern Ireland. From another who says, we are at crisis point and we need help from Stormont, otherwise NHS dentistry will cease to exist. And finally, my colleague who said, this is the last opportunity to save health service dentistry. Please take it. Thank you for listening, and we're happy to answer any questions that you have.
Thank you, and thank you, Ciara, for your contribution. I mean, I think that's been pretty stark. It's like most things we seem to be hearing, but I think often dentistry can be very much forgotten in the bigger picture, and I don't think a lot of us understand the real importance of the service. And you've outlined some of the key issues there and why it is so important. And as anyone that has ever had a toothache, for one example, will know, it's something we can't do without. And that's not even talking about all the other range of services and interventions that dentists are able to provide. So I think it is quite frightening at this stage to hear just how far gone this issue is. So I have a few questions, I suppose. You did mention there around in terms of detecting cancers, and just this week we attended some of us attended the NI Cancer Coalition launch, which you may or may not have seen, and I was speaking to some of the organisations that support people with cancer and diagnosis and create awareness, and one of the big issues that was raised with me was around head and neck cancers and just how important dentistry is in detecting head and neck cancers, and that's something that we are going to see a real rise in terms of people further in their journey as well, and before it's diagnosed. So I don't know if you want to maybe speak a little bit on that, just in terms of your experience or what you're hearing from your colleagues, and how you think that will escalate given what has happened in dentistry.
As part of a dental examination, we will examine all areas of the mouth for any signs of unusual surfaces, and those are the early stages of cancer, and as everybody knows, early detection is key to making sure that survival rates stay as high as possible. So by checking patients' mouths every 6 months, every 12 months, we can see those signs early and we can spot them. We don't just check the mouth, we check the back of the throat, we check underneath here, and we check the cervical lymph nodes. And I have had a colleague who last year sent their patient to their GP because they had persistent swollen glands, which they detected during an examination, and thankfully an early lymphoma was detected, and the patient then has had good treatment. Also, whenever anybody has a head and neck cancer, if they have any form of irradiation of your head and neck, then it has severe effects in the mouth because the salivary glands aren't able to produce as much saliva. You have a dry mouth, and then you're at an increased risk of mouth infections and a very increased risk of tooth decay, and you need more active dental interventions and more prevention than before. And obviously, if there is an access crisis, you cannot get in to get the service that you need as your wraparound care when you're going through another traumatic cancer treatment.
Yeah, no, thank you for that, and I think that just points out exactly, some of the really critical aspects to dentistry and how that can be life changing in many cases. You mentioned then, I suppose, obviously we need to see a solution to this, and I think it's very clear what that solution would look like. In terms of the engagement with the department, and I mean, I've made a note of some of the language used around broken promises and a lack of trust, and I think that's all very disappointing. I'm sure others will agree to hear that, because certainly what we want to see is the department proactively engaging with yourselves. I think everyone knows what the financial picture is, but we can't just close the door and say that's it, we're not doing anything on it. We have to make moves. And you mentioned the Scottish model. So in those engagements to date, has there been a discussion around the Scottish model and how that could be implemented here? And is there anything additional to that you think the department could be taking steps to try and secure the long-term viability of the service?
Yeah, Chair, I'll maybe take that one. So we met with the Permanent Secretary last year on a number of occasions, and towards the end of last year, the response was we wanted a cost of service investigation just to sort of bring an objective basis to the true cost to deliver care. The response to that was, let's look, there were developments in Scotland. Last November they implemented their new model, so the suggestion was let's take stock of what happens there, and that would be a logical starting point. And that hasn't come to fruition. And I think it was back towards the end of the year then there was talk of investment proposals being brought forward, because we knew there was considerable underspend in last year's dental budget compared to the 1920 year. It ended up 10.5 million underspent, and it was, let's look at the headroom to do something to sort of invest, use that money to get it out into the service. And then when it looked like Stormont was coming back just before Christmas, there was those investment proposals aren't happening, which is why expectations have been raised among the profession that Scotland was the logical starting point and that was being looked at, and then expectations were raised about these investment proposals coming forward, and then it transpired that no costings were given to the Minister about the Scottish model. There's a sort of wait and see approach being taken there. We know that Scotland, things have, it's not full reform there, but it has stabilised the service. And that's really what we need here. So I guess that's the sort of background to what precipitated our open letter in January. What's the plan? Because we can't see one.
And to date then, have you had any response from, in relation to that, what the plan is at this? I know I'm conscious we have a new minister in more recent weeks as well, but I suppose in the interim then, while From Stormont has been restored, has there been any feedback? Because we are 5 months in now, I think.
So the plan was the 9.2 million investment. Okay. That is the only plan that we've been made aware of, and we were made aware of it at the same time that the press were made aware of it as well. So there was no co-production, there was no co-design, there was no collaboration at all. It was a scheme which was designed by the department with no input from any dentists who are providing dentistry at the moment.
And as you said, Ciara, in your opening contribution, that 9.2 million was existing funds, it wasn't additional. So even in that, it wasn't exactly an investment proposal because it was already there. Am I right, Jeff?
Dentistry can't be delivered with the current contract and run a viable business, and that's why it's shrinking. And it's almost on the back of the failure of the service that this 10.1 or 9.2 million is being put back into the service on the back of failure. And to me, that doesn't feel like investment.
Yeah, no, absolutely.
As we're concerned, there is no plan. And when we're looking at the statistics that we gave to you, discussions among LDC colleagues, the first thing they say is anything else going to happen? And when we have no answer for them, they say, well, I don't have a choice now. I'm going to have to take myself out of the NHS. But their first question is anything else going to happen? The first desire is, can I continue in the service? I would like to continue in the service. I would like to look after my patients. And it's interesting, I was working the last few weeks because I knew I was coming here, and I was looking after my patients, and my practice is a mixed practice. We have some private, but we have majority NHS patients. And every one of my NHS patients was coming in, and I thought, I couldn't care for you if I wasn't working under the NHS. And it broke my heart. And it breaks the heart of every practitioner who is being forced out. And I think it's very important to understand that no one here is going to leave willingly, and yet the signs show that they are leaving. The requests to take patients off their lists so that they don't have to work under this system are all in the pipeline at the moment. So it could be, whenever you look at the statistics, you'll say, registration levels are quite high at the moment, but they're high because they were put on pause. So we have a situation where when you're registered, you stay for 2 years and then your registration expires. But because everything slowed down during COVID, there was a pause on that cyclical nature. And so registrations have crept up and up and up, but they will start to fall. But what is worrying is the level of deregistration requests, and that is in the pipeline. It's just about to come out of the pipeline, and I can't begin to stress the urgency of some kind of a plan that tells dentists, yes, you have a future, your business has a future, and you can continue to care for your patients the way you want to care for them.
Yeah, no, absolutely. And I think, I know even from speaking to in my own practice where I go, they had said to me that because they had another practice that was maybe a wee bit more top heavy with private patients, that's the only thing that they have how they've been able to hold on to their NHS patients, because that has stabilised it. But that's not an option for many. And even at that, it's very, very challenging. But as you say, Ciara, it's a loyalty to your patients, and it's your duty of care that you feel as a dentist. And it kind of brings me then to my last issue, and it is around health inequalities. And I think that's what's really jumping out at me here as well, is people who are entitled to NHS dental care are not going to be able to access that. And for many then, paying for it's just not an option. And I think the impact of that is going to be far-reaching, and we're thinking of children. I think you talked about in your remarks too about a parent with a child with a toothache. We've all heard, I think during COVID particularly, people trying to get an emergency dental appointment because of different issues, of how that was so difficult during COVID. But that's going to become even more difficult, particularly if you don't have the means to pay. And that's not a criticism of dentists by any means, but I think what we're going to be faced with is huge issues and for families and children and older people, everybody who won't be able to access dental care, and what that will mean for their health, but also in terms of widening those gaps and inequalities. and accessing healthcare. So I suppose just on the dental access scheme, and I know we talked about that, is there any further update on the implementation of that, or how that's moving?
It's due to be implemented in August. Business case, I understand, is being finalised at the moment. I think, and I don't want to have a fully negative meeting here. I think it is good to have a safety net for patients. I think it's very important for patients in pain to be able to access care. So that is a good thing. But I think if you look at it through the analogy of a GP, it's like making a new A&E service without actually creating and allowing the GP to look after the problems before they end up in A&E. So it is good and it is very, very necessary. But if we look back and say, actually, if we had a properly funded, successful dental service, you wouldn't need the dental access scheme, because we could throw open our doors and say, come and let me help you, because we can all make this work together. I think that, I just think the barriers are there, and nothing short of the Scottish model is going to lift those barriers. Helen, what did...
Yeah, I work in the out of hours, which is the emergency clinics on Saturdays and Sundays, and there was a PUPA scheme that was running to help treat unregistered patients and provide access during the week. But at the weekends, those patients are returning to the out of hours, because they're maybe getting root canals started, but the practice isn't able to take on that patient as a registered patient. So then they're presenting weeks or months down the line with the exact same dental programme, to get further root canal open or to have to get the tooth out. The problem is that patients who are unregistered are just phoning to the out of hours service wanting to be registered, and that's not what the remit of it is. And it is literally just firefighting the acute need, but if their urgent, non-urgent and routine needs aren't met, then the problems are just going to continue to exist.
I think it's the cyclical nature as well of it, where when you listen to the GPs who have patients on a waiting list waiting to get into hospital, and they have to return and get their symptoms managed. Well, that's what this system will do as well, is patients will need to return to this system because they can't get the routine preventative care. Can I mention one other thing on the health inequalities? So if you look, people from deprived areas tend to have more fillings. In general, they have a higher dental load, and all dentistry needs maintenance, so their ongoing needs are higher, not just today, but they're higher ongoing as well. So it's almost like a double whammy in terms of initially more decay because of deprivation and issues, and then more maintenance because they had more decay in the first place. So it is actually, even worse than it would appear on the surface.
Yeah, no, absolutely, and I think that is kind of along the lines where I was thinking, is that those people who are from a more deprived background it's further compounded because they're not able to access. And I think just my final point on that is, you mentioned about, you give the comparison with the GPs, but I think that even if people can't get access to their dentist in the that kind of normal routine of, they're ending up in A&Es, so that actually is adding to hospital pressures as well, because people's issues develop and become worse and can maybe lead into other health conditions. So it's all very relevant, and it feeds into that wider health system, and it puts a greater emphasis on why we need to tackle this. So thank you. I'm going to open up to other members, so I have Danny there first. Thanks.
Thank you very much for that. That's another stark presentation, and we hear these very, very regularly in this committee. It's almost weekly that a very important health service, branch of health service, comes to us with a crisis. Yours crisis is certainly very, very developed over many years, and it has just got worse and worse. And in fact, you were used as an example of other people we don't want to get like dentistry, because it's recognised that this is so advanced now that you can't get a dentist, and you have GPs saying we don't want to become like dentistry, but in fact they are moving along the same road. And I know some GP practices now have started a private element to their practice so that they can continue to support their NHS work. The problem is clearly the contract, and certainly we've met before, Tristan. We've had discussions around the contract. It's shocking that there seems to be a very, very low level of engagement. I get that this scheme has come out. I'm stunned that it wasn't discussed with yourselves, and the idea that a department would produce a scheme without any consultation, without any co-production, and just roll it out is absolutely shocking. I get that you think it's a good idea, and I'm glad that there are some benefits to it, that the inequality piece is absolutely huge. We're actually just pushing people into really worsening dental problems who live in our most deprived communities, which is absolutely sick. It really is, and huge concerns about that. Can I just ask, just to clear up the engagement piece with the department, when was the last time you had engagement with the department? Was that in March, just before the scheme was rolled out?
Well, I guess it depends on what issue. In terms of contract reform, which has been promised and talked about since at least 2011, if not before it. We came across a document earlier, this week. Michael McGimpsey was talking about a new contract, and you can see why people sort of lose heart and lose hope when nothing actually transpires. In terms of engagement, there has been, I guess there's a context here where this place wasn't operating, and I guess officials are limited to some extent maybe in what they can and can't do. But we did meet on a number of occasions with the permanent secretary last year to keep him and the officials abreast of issues. As I say, we met with the outgoing minister, on the day this was released, and the press release was out sort of before our meeting concluded. And this was the context of the open letter, as I say, that we didn't get a response to for quite a period of time either. And that was, 720 dentists from Northern Ireland, that's over 2/3, signed that letter asking what the plan is. You see from the written remarks, those quotes, it's not just PDA, this is the grassroots, this is the, where they're at. So it's been well over 2.5 years since there's been any serious conversations about contract reform. There just seems to be an atmosphere, I think. Anything is subject, nothing can change, is subject to sort of finance veto over policy developments. The oral health improvement plans, which we supported, which the Chief Dental Officer consulted on, and the consultations closed in March, all that needs funded. That's all about trying to improve our oral health. So there's stuff there, but will it be funded, or will it gather dust on the shelf? So I think the profession have lost hope and faith that in these current circumstances, things are likely to change. And as Ciara said in her opening remarks, I think the department probably feels that they've done their bit bringing forward these, what they call investment proposals, but really they anticipate another underspend in real terms this year, and that's what this is about. So
I just want to add, in terms of engagement, my practice was in the original scheme to look after unregistered patients, which is currently running until the new scheme comes in until August. So not as a member of or as a representative from the BDA, but there was a 1-hour consultation with practices currently delivering the service to help refine the proposal. But that was after the proposal was announced to the press, and after the proposal was written, and after the business case, I understand, had been submitted. So our feedback was not requested at the developing of these new proposals. It was requested at best halfway through, and it was a 1-hour meeting. And as I said, we're the dentists delivering the service. We are the ones facing the barriers. We are the ones looking after the patients. And I have to say, it's a source of great satisfaction to have a patient come into your practice and be able to look after them. They come in with a problem and we can fix it. But putting your other hat on as a business owner, if it's a situation where that patient's coming being looked after, but the department hasn't paid for it, you've paid for it out of your own business, I think that's a difficult situation. But the engagement, I think, has not happened. If we were to table our meetings, June, November, and the most recent meeting, so June and November were with the permanent secretary. The November meeting was because we said, can we touch base with you? And then the meeting with the Minister was to make the announcements. So I don't think that the engagement has been satisfactory. I don't think that the department are listening to the dentists who are delivering the service. And if they listen, they would understand better what we are facing in trying to deliver the service on their behalf.
Sounds very, very poor. Can I just clarify just with you? So the scheme was announced, the business case was submitted, and then feedback was sought from yourself about how the the scheme would look?
During the meeting, I was told, because I came up with a solution, which was I'll have a sessional where we open for a session, so patients will come in agony to where Helen is looking after them in the out of hours. They'll get that agony sorted out, but they will still have the ongoing underlying problem, the acute problem. So there was a discussion about urgent need patients. So those are the patients who need follow-up care. And I made a suggestion to say, well, look, what about dedicating sessions to that, so that from Helen's place they can come to one of the sessions and have the stabilisation that's needed after the acute problem has been sorted out. When I made that suggestion, I was told that, okay, that's not a bad suggestion, but the business case is pretty much written. So that's so I don't want to give you a misinformation. The business case is pretty much written, was what I was told at the meeting, which made me go, okay, and we're being consulted now, but it's pretty much written.
It's effectively a box-taking exercise that had no impact on the actual scheme.
I can't say for definite if it had an impact on the scheme, but definitely the scheme was pretty much, the case was written by the time we were consulted on how it was going at a practice level.
It certainly seems very back to front. And I think to be snubbed as a profession, I think it's quite rude as well. It is an offence to the profession. Thank you very much, Chair.
Okay, Danny, I have Diane online.
Thank you. So this is a bit of a wild card question, so forgive me. So I noted down that what you're saying is the fees are wrong, the contract's wrong, the failure to listen is wrong, and last year we had 22% less NHS dentistry than we had in the previous year, and we now have a waiting list of people waiting to leave NHS dentistry. You indicated that there's some merit in the Scottish model, but it seems as if it's the same model as we currently have, but with more money. Do you have a preferred model?
We look to Scotland and we see that it's better than what we have now. We understand that there are limits on the budget that is allocated at the moment, and we would like more ambition. We would like a better plan. We would like a gold-plated service that allows us to deliver comprehensive dentistry to all. But we're very realistic about that, and we know that the department cannot afford what we would like to deliver. That's a gold-plated service for every member of our population. That's what we would like. That would be the ideal model for us as dentists, to deliver a gold-plated service to everyone, but that's not realistic. So what we have done is we have said Scotland is realistic. It can be delivered quickly, so we've taken a pragmatic approach as opposed to a perfectionist approach. Because something needs to be done very quickly, because dentists are leaving right now, and as I said, when they leave they won't come back. That's why we have said the Scottish model is sitting there, take it off the shelf and roll it out. The Chief Dental Officer has done some oral health improvement plans. These are going to take time to develop, and root and branch reform is going to take time, and I don't think that we have time, which is why we've held up Scotland as the next natural move that could be done, that could be delivered. And then once we have the service stabilised, I think it would be great to sit around the table and develop some proper plans based around the oral health improvement plans and based around the government's understanding of what it costs to deliver dentistry at a practice level. So if we did rescue with Scotland and then reform afterwards with, again, it's going to have to be a compromise. I know we can't have a gold-plated service for all, but at the same time we do want to care for people who need it. So that's maybe not an exact answer to your question, but it's why Scotland is first, rescue first, reform after.
I think just to add, we've been told that we're too small almost to come up with our bespoke new contract, and that's the reason why we've been told that they're looking to other places. So, Scotland, in our survey that we did in March, 86% of practitioners said, they would be interested in looking into the Scottish model. So we've almost done that work in advance, that there's certainly, that's stabilised it, but that isn't contract reform per se. I guess we're having to move quickly just because of how difficult things are now, so we don't lose any more, you know, NHS dentistry. But I mean, in terms of the bigger piece and the vision that should be guiding, you know, the reform, I mean, a new oral health strategy is something we have been pushing on for years. We didn't get that because of resource, so the oral health improvement plans were about the sort of updating the vision and trying to improve child oral health and elderly health, oral health of the older adults. So, as you say, there's a two-step process. There's the here and now, because we can't wait, you know, how many more years on the contract reform piece.
Okay. Thank you. So I get that completely. That what you're asking for is some stabilisation in an emergency situation, followed by some reform. It would be good to keep contact with you, to have a look as this develops, just what reform would look like as well. I'm not a huge fan of a pile of strategies, I'd have to say. I kind of quite like action plans, because the Department of Health is coming down with strategies, quite frankly, none of which have any relevance to what's actually happening on the ground. You don't have to look very far, the mental health strategy, stroke strategy, cancer strategy. So I'm kind of keen to see what the actions are out of it. Can I just ask one last question? The last time you were here, we talked about the potential cost of the amalgam issue and new EU regulations. I did ask the former minister what that cost would be, and his finance officer came up with a figure that they'd asked for about 250,000, I think, within the budget. I then heard a figure of about 3.6 million. I know that you were doing some work on the potential costs. Have you finished that work, and have you any costings that are maybe more realistic?
The costings depend on what lens you look through. I think whenever we're looking at the costings, it's looking at dentistry the way it is at the moment, which is a hybrid level of dentistry. So we have private practice subsidising NHS practice within the one building. Whenever you bring white fillings into the health service, what you will do is remove the cross-subsidy that is happening at the moment between the two services. So to remove the cross-subsidy and to compensate for the cross-subsidy that is happening at practice level, we have worked it out to be just over £20 million in order to have practices cost neutral as they are sitting today.
And is that per annum?
Per annum.
Okay, that's much more significant than anything the department have told us.
And that's because it's taking into consideration the cross-subsidy. It's the cross-subsidy that is allowing dentists or practices to continue to deliver NHS dentistry. So you have to factor in that cross-subsidy when you take amalgam out of the toolkit.
Okay, I get that. Thank you.
Thank you.
Thank you.
Thanks, Diane. And Orlia.
Yes, thanks very much. And I apologise for missing the majority of your briefing. I was stuck in traffic on the motorway, so really sorry about that. But just a couple of questions. So first of all, in terms of the 9.2 million investment, and you were given that feedback that there was no co-production or input, obviously from the sector and from your profession. The chief dental officer, so did they have a role in, our input into that decision making? I'm conscious that our briefing's being delayed today from the chief dental officer, but we will hopefully have that briefing rescheduled soon. So I'm just trying to figure out, because when you have sort of, this position and this role, I would assume is meant to help and support and, basically support your sector in conversations exactly like this. So if you can just explain to me where the link in was there or lack of.
I guess it's very difficult to know in that we, because we had our meeting with the Minister, the Chief Dental Officer was there along with other officials, and the Minister and Chief Dental Officer really talked us through what the scheme would be at that point. So that's really, we assume then there was an understanding of the scheme as a whole, but as I say, we didn't have advanced sight of what that would be in advance. So.
Okay, well, I think that's something that maybe we will be coming back to when we're speaking with the Chief Dental Officer, because I just can't understand the rationale for that. Surely the sector has to be involved from the beginning, and that is the whole ethos of co-production right across the health service. So I just don't understand why that didn't happen, but thank you. My second question then, so in terms of the delay to adjusting the fees and the contract, Tristan, I know you said this has gone on many, many years now. So is the Department of Health giving you a sort of a rationale as to why this delay is ongoing for such a long time? You had mentioned because we're such a small place. Is it money? Do you have a clear sense of why this is being dragged out for so long?
Honestly, it's probably the same reason as why the cancer strategy took so many years. The idea of that you have a sort of dynamic policy environment where the needs are driving what needs to happen, where benchmarking is done, where best practice is applied. It's all finance driven. Anything that's going to cost money, it's a no, and it's, things are almost being curtailed and this, like, it's all this elusive, we get that the finances and the budget situation is really, really tight. But I would say it's finance driven at the minute, and that really concerns us. We all know that, you've got to cut your cloth accordingly, but at the minute, with burying the head in the sand, with not accepting the impact and the pressures at practice level, then it adds more and more pressure on practitioners who are trying to sustain these services, and they see no hope that things are going to improve.
Yeah, and I think pushing the can down the road is effectively doing nothing, and doing nothing is a decision. And that's what we're looking at now, and practitioners are looking to the department saying, well, by doing nothing to sort the contract out, you're making a decision to let NHS dentistry die.
Yeah, and I think that's really worrying, because one of you made a comment that basically the profession is at the point that you've just lost hope and faith. And I think that's the message that should be coming out of hopefully today's meeting to the department. And I've no doubt you'll have the support of the committee, I'm sure, and yes.
At the end of the day, this is our last resort. We have moral and ethical obligations to our patients, and when the cost to provide the service outstrips what we earn, we also have to have obligations to our families, to our staff that we employ and their families. And what has this left us to? So we can options are that we continue to have to pack more patients in to a short period of time. That increases burnout, which isn't good for us as practitioners, but it's not good for the patients, and it has the potential to create unsafe clinical practice, which nobody wants. The other things then that we're having to look at is, well, what other options do we have? If we don't have health service, then we have to be able to set fees that are financially viable, to sustain our own businesses so that we're not going bankrupt, so we're able to keep some form of service for our local community, so that some patients are still able to access dental care. And those are not decisions that any of us would take lightly. We want to support our local communities. We all know that we could make more money privately, but we value the NHS, are most vulnerable in society, and we want to support those people.
Yeah, no, absolutely. And I mean, I represent the constituency of West Belfast, so I completely understand, like I'm sure all members do. We would all be fearful that we're seeing a two-tier health system already creeping in. We already know that there is a growing crisis in terms of oral health inequalities. And, I know that even speaking personally just from my own area, I can see the real life impact that that's having, especially on the kids. And the chair had mentioned earlier around the pressures that that's putting on to the emergency department in the children's hospital. We did cover this previously, Tristan. I can't think of the stats at the top of my head, but it's the amount of emergency surgeries for children's oral health that they're having to perform in the children's hospital.
GA extractions, I mean, pre-COVID, you know, the scandal was the rate per head was 3 times in Northern Ireland compared to England. Now they can't even get through the backlogs to actually, you know, the waiting lists to do the GA extractions and the lack of theatre space. So, you know, it's just such a hidden problem, but so acute, you know.
And I think just finally then, Chair, sorry, but on the issue of the strategies, and I do agree with Diane, there's obviously frustration because of the financial context that we're in at the minute, that the mental health and the cancer strategies and other really, really important pieces of work that have been done aren't really going anywhere. The mental health strategy is 2 years and it's only receiving 1/8 of the funding required, so you're not seeing it filter down onto the ground. But I would say that the fact that the last oral health strategy here in the North was back in 2007, the fact that we see the growing oral health inequalities in our communities, and the fact that obviously your profession is now at the point that they're at in desperation and have lost all hope, we do need an oral health strategy, because that is how you will get your funding. Hopefully, if we're in a better financial situation with multi-year budgets and with additional funding from the British government, if we have an oral health strategy there, it can be funded, and then that's your plan, that's your longer term sort of sustainability, hopefully, for your sector. So, but again, hopefully it's stuff that we can all follow up on your behalf as a health committee.
Our concern is any delay means there will be less people to deliver the service, and I think that's where we would like to leave a message with you, is about the urgency of it. Sure. Is delay means losing dentists. So we can have the most wonderful strategies in the world and plans, but if you don't have the dentists to deliver it because they've all been driven away, then we can't do anything with it. So it is the urgency of it. And again, back to the budgetary considerations. If there is a limit on the budget, then the department then will have to put a limit on the dentistry, which that's their decision. But their limitation at the moment is to pay so little for it to drive dentists away, and that's why the budget has shrunk. So they need to make a decision. If there's a limit, then they limit the people who receive the dentistry and they receive everything, or they have limited by saying a basic service for everybody. And that's what limits mean, is you cut your coat according to the cloth. If there's a limit, then you set the limit, but the limit has to mean that practitioners can deliver the service on behalf of the department, and they can pay their staff and pay their bills. And I'll not say all of that over again, but by limit, if there is a limit, they have to be realistic, but actually make the plan and deliver the plan. And as I said, if it's a long-term plan is great, but dentists are leaving now. And we want them to stay, and they want to stay, and I think that's the most important thing to take away. It's not, right, that's it, we're off. It is, we want to stay, but the circumstances are such that we're being driven away.
Thank you. Thanks so much. Thank you. Alan Chambers.
Thanks. Ciara, just in your opening remarks, which is very useful, you were painting quite a bleak picture of the state of dentistry at the moment, and I think we all, in our own practices, we can see the issues that are going on. And I don't think that any of the aspirations that you're putting forward or thinking about are unreasonable at all. But what I detected in your responses there to some of the questions was that you have a sense or a level of realism about where we are at the minute. That the budgetary situation right across everywhere is dire, and you talked about a gold-plated service. So that would be your ultimate, and that's what we all love to see. But you also you said about compromise. You talked about compromise. So in other words, again, this is where the realism I sense was that a gold-plated service is, yes, we can aspire to it, but in the here and now, we'll have to settle for something a little bit, and then go forward and stabilise and probably provide a bit of hope to people, and then go into reform mode. But just in terms of dentist surgeries at the moment that have went private, all private, is there any possibility that they'll ever come back? Because I don't know what sort of a model the Scottish model is. I haven't seen the detail of it, But even if we had the Scottish model, which I think you've said it's something that we could introduce quickly, so it would bring that bit of stabilisation to dentistry, but I don't think it'll match what the fees that a private practice can attract, and I'm not even sure that that the Department of Health can come up with a scheme that possibly would match the more realistic, to a dentist, the more realistic fees that they can charge for private practice. So is it the case that those practices that have gone private, we can wave goodbye to them in terms of NHS? They'll not come back, because what incentive could we possibly offer? So would that be a fair assessment, that they're lost and they're lost forever?
I think that's a fair assessment. Once a practice has gone fully private, it will not come back. But the practices that you have a chance of holding on to are the practices who are at the moment moving away. So you can move away from NHS dentistry by saying, but you know what, I can only run an NHS clinic at a loss 2 days a week, and I'll run a non-NHS clinic, a private clinic, 3 days a week. So if you put in a service that allows those 2 days of NHS dentistry to actually be a successful financial business model, then practices would say, well, okay, yeah, I probably can do 3 days of this because it's not breaking the practice. So it is those dentists that are in the process are the ones that you have a chance of saying, look, come back, it's okay, it's going to be all right. The dentists who are currently providing NHS dentistry are the dentists who have already seen the model, it doesn't work, and they're doing it anyway. Their heart and soul is in it, but they have to, as Helen said, pay their staff, pay their
real
bills,
world.
pushed out, yeah. So if they could see, well, actually, this is going to be rolled out, it's going to be rolled out quite quickly, they say, well, do you know what, I can hang on, I can pause on that bill for 3 months, I can do that, I can make it work, I'll hang on, because there is something in sight that I can stabilise my NHS service on. And as I said, we want to do it. It's just we've been pushed out. So the ones who have left won't come back. If
I was just there said that we don't want to lose any more NHS dentists, and I think that's where we're at the moment, just to try and hold on to what's there. And obviously there is urgency to achieve that. Thanks very much. Thank you.
I think that's the situation we have now. It's the highly committed NHS practices are having to really reevaluate whether they can stay, and those are the ones that provide all the majority of the health service dentistry.
Thank you.
I just have one or two quick questions, and then I know Danny's looking to come back in as well. I suppose just, Ciara, you talked about the gold-plated service, and that's where you'd like to be. And I mean, I think that's so important. And I think even just come back to even as a child, you went to your dentist, it's very easy to get access. Can you give us any kind of even a time scale of where you've seen, was there a time where you felt that you could provide that service, that real high quality service, that you feel that your patients, you're able to give them your full, you know, everything, it's not the right term, but you know what I mean, in terms of as a dentist what you want to be able to provide for your services, whether they're are your patients, whether they're NHS or private, and compare that to now. And even if, you know, how, and what sort of a time frame have we, has that deteriorated, I suppose is what I'm trying to look at.
So if you look at some published papers on it and some reports, it was about 2004 that it was said that the legislative changes and the costs of care are not keeping up with the fees. That has been said somewhere. But from a personal perspective, I've been working in NHS dentistry here for over 25 years. When I joined the practice, the partner who employed me said, look, don't worry about the fees, don't worry about anything, come in, do your job, it'll all be fine. And that was exactly what I did. And I went in and I did my job, I liked my job, and it was fine. If you asked me to put a time on when I thought, oh, I'm going to have to quicken up my pace a bit, this isn't working, I would say for me personally, about 10 or 12 years ago. And each year, as I listen about cross-health efficiency savings, I can't describe how efficient dental practices are. There's every efficiency saving has been applied year on year as we've looked and they said, okay, we're taking away commitment payments. Okay, you can't do this. Okay, you can't do cleanings every 3 months. You know, with each one of those you go, okay, well, I can make it work because I'll do this. Okay, I can do this. I can do a little bit faster. I can see more patients. I can work through my lunch. I tell you what, I'll open an extra session of an evening, and that will mean at the end of the month I can still pay my bills. So if you ask for a time frame, 10 or 12 years ago, it started to be, had to get your running shoes on to get on the treadmill to make it work. And now the treadmill is running so fast.
No, and I think that's a pretty good analysis, and it's definitely very helpful, and it gives us a bit of a scope as to where the issues really started, and where we are now. And I think the deterioration seems to be very drastic. And the other question just wanted to ask, and I think it probably you've sort of answered it, will be the impact on innovation in dentistry, because people just won't have the time or the capacity to look at innovation and other skills and things, because they're too busy trying to just see the people they need to see.
So there's a revolution going on in dentistry, as in many parts of health, a digital revolution. And so digital scanners, transferring information electronically, this is all fabulous. We have new materials coming in that are fantastic. You cannot buy these things when you are running a fully NHS practice. A scanner comes in at £20,000 and we get paid £17 for an extraction, £10 for a filling, £8 for a checkup-ish. I'm going to say ish, those are not exact figures. You need to do a lot of those to pay for a £20,000 scanner to get up to date with the technology. So what is going to happen is health service practices are going to fall behind in terms of technology, and new graduates who are coming out who are trained in the technology as an undergraduate are going to be looking for that, and therefore they will overlook the NHS practices who have been in a system that has not allowed them to reinvest in their businesses. As the hybrid model, as we said, is the model that sort of is the one that's working in Northern Ireland, and that, you know, the hybrid practices are able to invest in technology using the income from the non-NHS part of their business, but wholly NHS practices will be left behind because you're running so fast on the treadmill you can't look left or right.
Yeah, I'd say just those figures you quoted, Ciara. I know I'm kind of going on a wee bit now, but just as we go through this, it is bringing up more questions. The £8 and the £10 for certain treatments, that's for everything, isn't it? Is that for your whole treatment?
If you do a filling for a patient, a single surface filling for a patient, then that includes your anaesthetic, it includes your filling material, it includes paying the nurses working beside you, servicing your equipment, your IT contract, your 8 insurances that you have to have before you open your door in the morning, the reception staff, your IT support, your accountant support, your professional fees, your professional indemnity fees. You have to cover all of those out of that £10.
Isn't it?
£17 for an extraction. And I want to tell you about an anomaly. This is down a rabbit hole, I know, but if we take out 4 teeth, we only get paid for 3 of them because apparently the 4th one is free. Now, there are so many anomalies built into the contract that take things away from practices that, Helen and I could list pages and pages of it. When you make a denture for a patient, it's more attentive if you put clasps on, but there's no fee for a clasp. But then if you put a clasp on afterwards, you get a fee. You probably there's hundreds of items on it that are not interlinked. So, but the answer to your question is that fee is supposed to cover everything. Now there are allowances in practice as well, and it would be remiss of me not to mention the allowances. So there's the fee for the treatment, and then there's a background allowance. So you get paid to have a patient on your books. It's about 90p per adult per month on your books. You will get a certain percentage as a practice allowance based on your turnover. Now, I have, within my own practice, monetised these, because when you look at a spreadsheet, you look at your hourly rate coming in, and this is my business head and not my dentist head, as you can tell, but you look at your hourly rate coming in, your hourly rate going out. And I thought it was very important not to be disingenuous about the item of service fees and to, what do those allowances mean for my practice? And those allowances are worth about £20 an hour coming into the practice to help cover the cost, but it costs about £60 in my practice an hour to run it. So there's a baseline of 20%, and then you have to add everything else on top of that. You have to do the dentistry in order to get up to cover your costs, to pass your costs, and also pay your dentists as well. So there are certain things that you do in dentistry that you don't get paid for. So if a patient comes in with a broken tooth and you do a temporary dressing, there's no fee because that's covered in the allowances. if you're this included the children's payments as well, by the way, that £20. So if a child comes in for a checkup and X-rays, there is no fee for that specifically, because that's included in the allowances. So there's so many things that have had to be covered by the allowances that it's gone way beyond. It's a bit like if you say to your teenage child, there's £50, and they say, well, I need a new blazer, should take that out of your allowance. Oh, well, I need new shoes, take that out of your allowance. Take it out of your allowance. So, we have all these legislative changes that have come in. We need washer disinfectors, we need a full decontamination suite. All those pieces of equipment need to be validated. It's paid for out of the allowance. It's paid for out of this bottomless pit, which is a finite amount of money. So, I have to be honest and say there is a baseline, but the baseline is not a lot of money, considering the level of costs that we're receiving. As I said, it's no exaggeration to say 8 insurances before you open your door.
Yeah. No, and I think, I suppose what the point I was going to make is minimum wage is nearly more than probably what is covering the rate. Yeah, so I think that's absolutely shocking, to be perfectly honest. I probably could ask some more questions, but I know Danny's waiting as well, and we've gone over time, so I'll leave it at that, but we may come back. Danny, go on ahead.
No problem. Thank you, Chair, for bringing us back in again. 2 things that really struck with me. I know you had said that you'd been requesting a cost of service delivery from the department, and that has been a request. First, is there any serious movement on that? Have you had any development from the department on that? And do you have a figure yourselves on what it costs, and what is the difference between what the contract costs at the minute and what you think a fair outcome would be, and how much that would cost? And just the second question, or the second thing I wanted to pick up was the GA extractions for children. We had heard about that previously. I know it was mentioned previously in another briefing to this committee. That's a horrendous thing to think, that there are children suffering on a waiting list, on a backlog, in severe pain, I imagine, waiting to get their teeth extracted under general anaesthetic in hospital. And I'm just wondering, how many, are you aware of the figure, how many children that is, what the trajectory of that is, and how long they're waiting in pain?
So last summer we did quite a big piece of work. We requested, figures for a lot of sort of to try and get a handle on the sort of number of patient waiters and length of time waiting within dentistry across all of the services. So maybe it's something after we could provide the committee. The figures are obviously at a point in time. I think it was last summer, but we did that piece of work. I mean, the issue is, because GDS is under such pressure, and it does 90% of the dentistry, then what you're finding is then the other services. I mean, speaking to our hospital colleagues, what the big issues are for them, other than workforce, it's the inappropriate referrals, it's the pressures that a failing GDS system is having on other services, and the same with the community dental services who do the GA extractions for kids. They really did not. I mean, it's something we raised with the department over a long period of time. They weren't getting access to the theatres, this theatre slots to be able to do GAs. So, there's been some movement there and some recovery. But I think we used the word candour deliberately in the opening remarks, because there needs to be candour around our oral health outcomes as a whole and how the system is failing. Because short of, we're so grateful to the committee to kind of give us the time. Short of, some media outlets picking up individual stories, I think there's real issues there that need to be delved into on behalf of our community colleagues. In terms of the other question on GDS and cost of service, I mean, this was raised a number of times with the previous minister before Stormont was suspended, and also with the permanent secretary, and there were commitments given that yes, they would hold cost of service investigation, and then when we pushed Peter May at one of the meetings, well, it was Scotland would be the logical starting point. On costings, the BDA have just completed a timing study which will be published at the end of this month in the British Dental Journal, and that was comprised of dentists from each of the 4 nations, sort of looking at the time taken and doing some costings around that. So there will be that piece of work, and we invited the department to observe that, and they did. So as I say, those will be published. I think the key thing really is around we talked about this trajectory, this downward trajectory. As our costs go up, there's no mechanism to mitigate increased costs at practice level. So, bad enough, we represent salary colleagues as well, and if they don't get their pay uplift, if there's a delay, as there is over a year, later. But if you're running a business and providing a service, and if you're not only if your actual costs are going up in excess of the uplift, last year we got a real result. We've been really majoring on that in our evidence to the Doctors and Dentists Review Body, and they specifically said they do not recommend on the expenses element. That's up to devolved governments, national governments to have those negotiations. So that's in black and white, and we've done a lot of effort with the department to try and find a mechanism, to objectively look at costs as they go up year on year within dentistry. Because if you had the ideal contract tomorrow, unless you've got some provision there to review that each year, it's just going to go like that. And that's why it's been going like that, or maybe no pay uplifts during the public sector pay cap. So that's kind of at the heart of this. This is transparency. That we've kind of given you the warts and all in our briefings, and the more objectivity and the more transparency around these issues, I think the better that we actually can move forward on a ground footing. Because it's not us wanting to be the troublemakers or it's almost got to that point where we're agitating when actually there's a really vital public service here in real jeopardy. And that's not to mention we haven't gone into depth about the community dental services or the hospital dental services, who are also on strike in alignment with with their BMA colleagues. So huge issues impacting on dentistry here, and we just need a plan, I think, linked to a new vision.
Yeah, and just to follow on from what Tristan said about the timing study, that did input into the development of the Scottish payment reform model. The BDA did input their timing study to that. So I think that's why, again, we're sort of holding it up as something that has been fully investigated and fully costed. And just one other thing on the DDRB that Tristan brought up. This year they applied a new approach with dentistry where we're 15 months late with their application. The uplift is only for 12 months. So by the time they have applied the uplift, they've already dropped it. So, for us, this is a new approach that has been developed by the department without consulting us, and has imposed effectively an immediate downgrading of the DDRB recommendation before it's even put into place. No,
I think that's an important point, Claire, so thank you, Jenny. And I suppose just then, in conclusion, and what I certainly feel that is coming out of today is that you guys are here today to fight for this service on behalf of your colleagues, but most importantly on behalf of your patients, because to me it seems that nobody else is. And I think even in terms of the attention the issue is getting in the public forum is very, very limited in comparison to some of the other issues. And everybody's issue is important. It's not to take away from that. But I think we'll be at a real collapse before anybody sits up and listens. And hopefully then as a committee, that's where we can come in now, that we have the information, because I don't think anybody can dispute what we're seeing here in front of us and how critical this is. So look, thank you all. We really appreciate your time. We really do, and for that real in-depth insight into what's happening on the ground. And hopefully as a committee we will have some actions coming out of today's discussion to try and take this forward. But anything else in the meantime, feel free to keep us informed through correspondence. We would appreciate that as well.
Thank you.
All right.
Thank you.
Okay, members, I've one I suppose request that we could potentially do in the first instance is to try and get a response from the department in terms of the recommendations that the BDA have outlined to us, to see where they stand, and maybe they could bring that to us in their briefing paper when they come. I know it's supposed to be today, maybe it's obviously to be rescheduled, because I do have real serious concerns about where this is leading, and it's something that affects everyone if they can't get access to their dentist. So are there anything else members would like to, Orlia?
Yeah, I just think, well, obviously we should mention the urgency that was outlined. I know I missed part of the briefing, but they were talking about that percentage of dentists that are thinking about leaving or going into private practice. I think that needs to be stressed in the letter, and I would also be mentioning the fact that the Minister has says that one of his priorities is around health inequalities.
Yeah.
You know, just making the point that we welcome that, and this will have a big impact in terms of oral health inequalities, which you'll know anyway. But
no, I think that's a good point.
Yeah.
Absolutely, and I suppose something that struck me in the middle of that conversation was too that whilst there's the greatest impact is on patients who require NHS dentistry, there's also an impact on the working poor, because if they have to increase their costs elsewhere to try and stabilise the service that they're providing, then that will impact on families who are kind of at that lower end of the, you know, who still have to pay for their dental treatments but maybe aren't as well off as others. So do you understand what I'm saying? So it's actually got an even broader impact, I think, than what maybe we realise. As dentists are trying to find solutions to keep their practices open and access for NHS patients as well, and trying to balance the books and all of that. So I do think it's very concerning. Danny, come on ahead.
Can we include just an update on contract reform negotiations?
Yeah.
I think that's very important. The other thing as well is, I know we were due to get a briefing from the Chief Dental Officer today. Obviously that hasn't happened. I think we need to get that urgently.
Yeah.
I know we've only a couple of sessions left before recess. Is there any way we could, we don't know when that particular person may be available, but could somebody else?
We have asked. Yeah. We'd asked for today, but they weren't available. So
would that be possible over the next couple of weeks, or is that?
We can ask and see.
I think with the urgency, I think that's important.
No, absolutely. Alan?
Sure, I have to apologise in advance. I have to leave at 3:30, but I'm hoping your quorum's okay. But just in relation to go back to the dentistry, the Scottish model, I wouldn't mind seeing the detail of it. You know,
Yep.
what is it, and how does it compare with what they're getting paid at the moment? It'll give us a better perspective of what we're actually dealing with here. And maybe when we look at the Scottish model, we'll maybe feel that it's not even, doesn't go far enough. That,
and I think that's what they've said.
So I think it'd be useful to get that and a comparator with what they're currently getting for treatment.
No, absolutely. And I think even what they've said there today was it probably doesn't, but it's something, and it's better than what they're doing at the minute. So it would be good to get that comparison so we can see exactly what they're talking about. Okay, no, thank you, members. Members, the next item then is number 6. It's a written briefing on addiction services. So if I can refer you to page 52 of your pack, and if anyone has any questions or any comments they want to raise at this point in relation to that. Malia?
Yeah, no, just there's a lot in the written briefing. It was very useful. I know that it was referenced in some of the content that came out of the addictions report as well, that was led by the Public Accounts Committee. So it's just what we do next, or what we do with this. So it's a good briefing. There's really good detail in it. There's really stark statistics in it in terms of the worrying increase of particularly drug deaths. So it's just, I know that again that it was one of our sort of committee priorities. It's just what we'll do next, or when we'll come back to it, and in what sort of shape or fashion we'll come back to it.
No, absolutely. And I think on that, and it references in the briefing that 42%, because of the budgetary situation, 42% of the actions are not progressing as planned. So if we could maybe get more detailed information on that, I think would be useful in terms of where we go next. And we will be getting regular briefings on this, as it is one of our priorities. But it also ties into the Minister's priority on their mental health as well. So I think it's important if we can get that information, and that might help to inform us where we go on it as well. Is that okay? Right, Danny?
Yeah, when we're talking about, it is one of our priorities, when we talk about getting regular briefings, is this the format that we're going to be getting them, and will they all be in writing, or are we going to get an in-person briefing with the opportunity then for further development and questions?
Certainly, Chair, we can arrange that. The initial one was to be a written briefing to get it early, but certainly throughout the next session we would look to schedule briefings.
Yeah, no, absolutely.
Just on the back of Danny's point, because I know that we did have the briefing from the mental health champion, which was great, but I think that the important engagement for the Health Committee is going to be with the department, with the officials who are working day and daily on mental health and addictions, so we can really scrutinise what proportion of funding is going to the strategies, you know, the progress of the new mental health, the new regional mental health board that we got the briefing at the APGs yesterday, you know, the outcomes of all of that. And especially that substance use strategy in terms of how we're trying to prevent some of these drug deaths. So I think that would be helpful to have more of the face-to-face briefings with some of their senior officials, because there's loads of good work that's ongoing. But I think it's important that as a committee we're across it and to see how we can help support it at committee level or in plenary.
Yeah, no, absolutely. And I think you're right, the APG on this week was excellent. It was good to hear that in terms of what the plan is around that. So yeah, no, absolutely. Is there anything else then on that one? No. Okay. So then item number 7 is correspondence. If I could refer you to page 65 of your pack, and from page 67, then it lists the different responses that we've received. The first one is a response from the Minister, or a letter on the Public Health Bill, and the consultation will be commencing from the 5th of July on the principles, the policy proposals. We also received a response in terms of workforce, and I suppose it's actually quite timely in terms of the meeting we had this morning or this afternoon with NIPSA in relation to the huge rate of vacancies in children's social work and children's social services. And I suppose it's disappointing that we haven't been able to get an understanding of the actual rate of the actual number of vacancies across the health system, because it doesn't seem that it's being measured. So I don't know if anyone has any proposals around that. Is it something we can ask will they consider measuring? Because I think, given that we've had another briefing today from another sector within our health service, and every single briefing we have is in relation to workforce. Yet the department is telling us that they don't actually measure or record the actual number of vacancies. It's only what is being recruited for. So I think we do need to go back and potentially say, is this under consideration?
Yeah, sorry, Chair, the department said that they are working on a measure with HSC to resolve the issues that there are in bringing that figure together, and they will keep us updated in developments, so we can certainly follow up and say we'd like further information once that's developed.
No, I think it's important, because it is one thing, and some of the, I suppose, information we even got today, and the concerns around progress in filling posts is concerning. So I think, you know, anything we can get to move that along would be useful. We had a response from the mental health champion as well, and there's a number of other items there. Is there anything anyone wants to raise on any of those? I have a few points, but I don't want to go through them too quickly. No. I would suggest if members are happy that we write to the department to get further detail on what actions in the mental health strategy have been prioritised, because it does say they are prioritising, but it doesn't say what. So are members happy enough with that?
Definitely, yeah.
Let's see, just go through if there's anything else. Just on the item on the serious adverse incidents in the cervical screening, we are due to receive a briefing from officials on the 27th of June on SAIs. So I think we can maybe ask questions directly on that. Item 7.7 is the response to the Economy Committee on the Departmental Cooperation and Support for Child Minding. As members will know, I think it was one of the first meetings we had with the Minister would raised around child minding ratios, and we'd asked for an update on where that is at, because we were told that was being reviewed. So I was told it was coming fairly imminently, but we haven't received that yet. So just we're waiting on a response, and then maybe if we can go back to see if there's any update on that. And then on the ministerial correspondence on the EQIA of the 24-25 budget, our members consent to receive confirmation from the department that the department priorities will be published in the interim. I mean, I certainly feel that we need to know more about what is being prioritised. We can't wait for the outcome of the EQIA for then the minister to say, well, this is what its priorities are. I think we need to be looking at what will be done in the meantime, because I'm conscious that if the EQIA is only starting now, it could be after the summer before anything else happens.
Yeah.
So our members happy with that. And then the correspondence from Emer's Wish on stem cell donor awareness. I know we've all been contacted by the charity, and it's a very important issue. I know certainly my own family have been impacted by how crucial stem cell donation is, and many other families across all of our constituency. So our members content to get an update from the PHA on what work they're doing or any plans they're doing to promote and raise awareness around the importance of stem cell donation. Okay. Our members content then to note to note the others and the suggested actions on the correspondence list. Okay, item number 8 is the forward work programme. If I could refer you to pages 187 and 188 of your pack. As members will be aware, the Oireachtas Health Committee had delayed its visit to meet with us by a week. So this will now be taking place on Monday the 24th of June, and the timings remain the same. And just again to stress that we really need to make sure people have confirmed if they will be attending that, because a lot of work has gone into organising that. And I spoke to Professor Mark Lawler at the APG for Cancer this week as well, and they're obviously hosting us at the research centre in Queen's. So it is a very, very good opportunity. So hopefully we can get as many there as possible. But if we could please let the clerks know, because it's for planning purposes. Then we have a visit to the Fire and Rescue Service Learning and Development Centre in Cookstown on Thursday the 27th of June, which is the following week. Lost in the days here now. But just again, if we could confirm attendance so that the committee staff can make the necessary arrangements, and then committee meeting will be in 2 p.m. as normal in the afternoon. Are members content then to note the briefings as set out in the forward work programme? Have members any other business?
Sorry, Chair, just in relation to that, is there any space that we could have a briefing from the department just about dental services? Is that?
We will have a look at see where that could be scheduled.
Because we've only 2 meetings.
Yeah. No, absolutely. And listen, I suppose if there is somewhere that they can meet us within it, we'll just have to make space, I think. Because I don't think we can put it off.
Yeah.
Is that okay?
Great, yeah.
Okay, members, no other items of business. The date, time and place of our next meeting is next Thursday the 20th of June at 2 p.m. in this room 29. So thank you all, and stay home.
Committee Room 29. Sound. 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 Committee Room 29, 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 Sound.